Alrighty, hi everyone. My name is Joel Noble, and my project was on the use of deep learning to generate synthetic CT from diagnostic CT for expediting palliative radiotherapy. And I have my supervisors listed there, who I've been very fortunate to benefit from their experience and insights. So palliative radiation therapy in WA, what is the problem? So for starters, around 50% of all cancer patients receive radiation therapy. And of these, at least in Sir Charles Gardner, around 46% are palliative patients. Now, the goals of palliative radiation therapy are, well, the main one, of course, is increasing the overall quality of life for these patients while minimizing the burden that treatment places on them and ideally reducing their reliance on medications, particularly pain relief analgesics. So Australia-wide, in 2018 to 19, it was recorded that it took 18 days for 90% of palliative treatments to go from the referral stage to the first treatment. And combined with this, the pain relief has a median time of 2 to 3 weeks for 60% of palliative patients. So if you put these two facts together, and consider that palliative patients have a median life expectancy of 5.6 months. A quarter of their remaining life is taken up by waiting for treatment and then waiting for the actual pain relief from treatment. So clearly there's plenty of scope for improving this. And if we look in WA in particular, we see that we had the second longest wait time for radiotherapy in general in 2018 to 19 of 90% of our patients treated in 34 days. Bearing in mind that's for all radiotherapy, not just palliative, but still that means that WA trends with longer wait times. And this is related to the conventional workflow where there is a bottleneck. So if we look over to this map here, so you can see the entirety of the UK fits quite snugly in WA. As you all know, it's quite a large state. Meanwhile, the actual radiation therapy clinics are localized in the southwest here. So if we consider a patient, perhaps Jane Doe, who lives in Carnarvon, she has to come all the way, drive across the entire United Kingdom to get to a clinic for her planning CT simulation session in the conventional workflow, and then return back home and wait generally around 2 weeks. Meanwhile, her symptoms are progressing, and then she can return again for treatment and then return home again. So that's quite a lot of commuting. It places strain on herself and her caregivers. So what if you could just come straight to the clinic with a simulation-free process and then just return straight home? Well, that's what this project seeks to achieve. So simulation-free radiation therapy, the crux of it is recycling a patient's diagnostic CT. And it's been a growing initiative since around 2019, especially in the palliative space, where you're working with broader dose constraints and a greater impetus to expedite treatment for the pain relief. And the overarching goal of SFRT is reducing wait time and effectively halving visits if you are talking about single fraction radiation therapy, which is what most palliative treatment is. So there are a few different avenues for SFRT. There is, of course, just directly using a patient's diagnostic CT, but this does place certain constraints on them, including the lesions and the sites of lesions that can be treated. It excludes patients based on implants and prosthetics, introduces its own alignment and reproducibility issues, which have been addressed by some studies using vac bags to recreate the positioning of patients as they appear in their diagnostic scans, but that does, of course, add extra steps to the workflow that we're seeking to expedite. And there is also a constraint placed on the interval between diagnostic and planning CTs of generally less than 30 days. Now, some of these issues can be addressed with adaptive radiation therapy to adapt plans on couch, but especially if user licensed software such as Varian's Ethos platform isn't available, this can lead to on-couch times in excess of 45 minutes. So there is another avenue, which is CT to CT translation using deep learning. So the idea is if you give a model a diagnostic CT, it could deform it, such that it would resemble the planning CT that would otherwise be acquired. And this is a very novel approach to SFRT, which is already a novel field in itself. And the crux of this initiative, this third avenue, is what you can see here, where there's a deformation field being applied to a Diagnostic CT, which has more pronounced anterior girth and more pronounced posterior curvature due to the different couch shapes of the diagnostic and the planning couches. The diagnostic couch is curved for comfort. The planning couch is flat for ease of reproducibility and factoring into a more consistent patient setup. But of course, that introduces these misalignments which need to be addressed. So the aims of this project, the first one can be encapsulated in end-to-end deep learning model creation and evaluation, in particular using a cycle generative adversarial network for synthesis. And the second aim is treatment planning on the synthetic CTs output from that model for clinical quality assessment through clinical goals, dose volume histograms and their metrics, and isodose maps. So an overview of this project's workflow, starting at the top here, diagnostic CTs and their corresponding planning CTs were collected, and a subset was created with a fairly conservative constraint of less than or equal to 6 weeks between the diagnostic and the planning CTs, which is still an extension upon the current literature, which generally doesn't exceed a 4-week interval. And there were 2 main pre-processing stages of removing the couch from the diagnostic CT, and then of course doing the registration from the diagnostic to the planning CT. Firstly, rigid to get the input data to the deep learning model, just a rigidly aligned planning CT. And then the deformable registration was done by velocity, which of course is what the deep learning model will try to learn in the absence of having an image to register to. And then the 66 scan pairs were used in deep learning, so there was a lot of model experimentation which occurred before final post-processing pipeline on the test cases, which were then brought into the planning phase, where on Eclipse T-Box, automatic contouring was done, actually prior to that, but that was done to, of course, help with evaluating OAR constraints. And a new plan was made on the synthetic CT that was copied onto the planning CT as well as the diagnostic one. And then the different organs at risk and target volume constraints were analyzed and seen if there were significant differences across the different test cases to ultimately evaluate if this was a feasible approach to SFRT and if it could indeed expedite the conventional approach. So a bit more information on the patient cohort here. So 58 patients in total. Some of them had multiple scans, which is why there's 66 scan pairs in total. And of interest, of course, is the actual distribution of treatment sites. You can see the majority is lumbar only, but a bit of variation from the thoracic and lumbar region, and even a cervicothoracic and a pelvic patient in there. But again, mostly lumbar, so looking at the abdominal region with a bit more diversity in there. And you can see the average interval of 2.8 weeks between scans. So a bit of information on the actual deep learning network being used. So starting in the top left, you have a rigid input coming into the encoder side of a UNet. So UNets are popular for deep learning model for synthesis, and they have this sort of U structure with an encoder followed by a decoder. So the encoder does the spatial downsampling. So you can see what's happening here is that in each layer or chunk here, the input is being spatially downsampled while the number of channel dimensions is increasing. So this encoder is forming an ever more compact representation of the input while increasing the number of channels to learn more abstract representations and learn the feature relationships which are going on inside the input image. Eventually it gets down to this bottleneck layer where it's doing very highly compact feature abstraction. And then it moves to the decoder where it does the opposite. It does spatial upsampling and it's decreasing the number of channel dimensions and reconstructing the input while having these skip connections. This is another characteristic part of the UNet, skip connections from the encoder to its corresponding decoder layer, which is to help when reconstructing the inputs, just to give a bit more spatial context. There was also within each layer these shortcut connections, which help with preserving that spatial context and reducing the amount of response required by each parameter of the network in order to actually learn the relationships that are happening here. And I'll also mention that this is a fully convolutional neural network, and the foundation of convolutional networks is hierarchical feature extraction in the same vein as a human visual system, which is partly why they are so ubiquitous in image synthesis, because of course that's what our eyes do. And then coming out of the decoder, we go to a final bit of post-processing at the input spatial dimensions, but at higher feature dimensions before giving an output of the same spatial and feature or channel dimensions as the input, which ideally is deformed suitably. So this another submodel composing this deep learning network was what's called a patch GAN discriminator. So similar to the encoder side of the UNet, it takes in an input, a CT, and then it downsamples that one, and its output is essentially a downsampled version of the input with a reduced number of voxels or patches, where each one has a value ranging from 0 to 1, which says how confident that discriminator is that that patch belongs to a real or a fake image. So with these two models in mind, the generator and discriminator, let's talk about the adversarial game that they play. So starting in the top left, you have a real input coming into the generator, and it produces a fake synthetic output. And then that, if we're just looking at how the generator is trained for now, that is passed to the discriminator model, which it's been given a fake output, but then you compare that over here with a real target output, and you see how well has the generator fooled the discriminator into thinking its fake output is actually real. Meanwhile, the discriminator is given a real input over here, and that real input is compared to a real target, while that fake output from before is compared to a fake target, and you say, how well has the discriminator been able to tell real from fake? So this is the two-player game that's going on between these two models, and this interplay is precisely what makes GANs so good at image synthesis, because it helps force a more appropriate domain mapping from the generator rather than just having a UNet by itself, which can go a bit abstract and not quite learn what you want it to. There's another game going on, which is this cycle consistency. So if we start at the top here with a rigid scan, it's being passed to the deformed synthetic generator. So this is going from rigid to deformed image, and its output, right, is then passed to a rigid generator, which is going in the other direction. So that's going from deformed to rigid. And then you compare how well has that rigid generator reconstructed the original input over here, and vice versa. You do it in the other direction. So you give the model which goes from deformed to rigid, you give it a real input, and then you see how well is the one that goes from rigid to deformed reconstructed that input. And the idea is, if each generator can work in both directions, you are promoting anatomic realism. So this is something like a form of constraining the model's outputs to work both ways so that it's more anatomically relevant. So with the model architecture and broadly how it was trained in mind, let's look at the actual training charts themselves. So I did 5-fold cross-validation. So I had to split my data into 5 big chunks, aside from the test set, of course. And looking at the combined training loss in the generators, you can see the 5 folds here, and fairly consistent interfold performance occurring. You can see lower training loss in the folds 3 and 4, which is correlated with their higher validation loss. So it seems like those 2 folds were overfitting, is what they call it in deep learning, essentially just learning the training set too well and not being able to generalize to unseen data quite as well. But overall, fairly good trends for what you want to see. There's a clear elbow in the validation loss, and then it starts to increase slightly. But it is, of course, difficult to fully qualify images using a quantitative metric like the mean absolute error, which is what the validation loss was. But still, it helps just confirming that the training went well, which it did. And looking at the actual outputs now from these models. So starting on the left, you have the synthetic CT. This is after prediction aggregation and post-processing to just improve some of the tissue boundaries there. And you can see pronounced posterior flattening, considering that this was given a rigid input with more curvature in the posterior there. And an adequate weight loss prediction. If you look at the error over here, you can see a bit better that it is still extending in the anterior and lateral, anterior and posterior dimensions a bit more, but it's done a fairly good job. And I'll just emphasize this was on a test case. So this is unseen data that the model was given to predict on. And then finally, there is an uncertainty map over here, which reflects the fact that each final synthetic CT was from an aggregation of 5 predictions, and the uncertainty corresponds to the standard deviation of those 5 predictions. And you can see the models were more uncertain in the areas of deformation, which is what you'd expect. But unfortunately, they weren't too uncertain in the interior or the deeper anatomy, which corresponds with where there's displacement occurring around the bones and tissue interfaces. So now looking at some quantitative metrics. So starting with some pixel-wise metrics, and you can see that the deformed synthetic output performed better than the rigid input across these metrics in each case, as you would hope and expect. Now, if you compare this to another study, Rowshanfarzad et al., who did CT to CT translation, except for expediting pancreatic cancer, you can see an improved root average squared sum of differences of my model compared to theirs. Meanwhile, for Brani's CBCT to CT domain transfer model, his best cycle GAN achieved improved metrics, but still comparable to mine. And looking at the structural similarity, you can again see that synthetic CT improved marginally on the rigid input. And moving to actual region overlap, so you can see a slight improvement in the dice of the body contour. Dice is essentially just measuring the overlap between 2 contours. But you can see it actually started out quite high for the rigid, which I suppose is a testament to how well rigid registration does actually overlap these volumes. But unfortunately, in the bone regions, you can see that the synthetic output actually has a lower overlap than the rigid input. So that's suggesting that the model isn't quite predicting bone, or it's deforming bone a bit more than it should be. Although it has preserved soft tissue quite well, you can see a slight improvement in that. And looking at the Hausdorff distances, so it's like your worst case displacements, you see a similar trend where the rigid image actually, on average, for these Hausdorff distances, doesn't have as drastic displacements. So again, occasionally the model, when it was wrong, it could go more wrong. And if you compare that to Rowshanfarzad's study again, while I outperformed them for root average squared sum differences, they performed better across body contours and displacement errors, which perhaps is related to the fact that they were working on a smaller Z range. So perhaps the model could just learn a little, it wasn't working at as many extremities from sort of the ischium bones to the cervical spine, which could, of course, lead to more errors in the model prediction. Now, that being said, if you actually look at the contours themselves, so we've got on the left here an overlay mask of the body mask, you can clearly see how the rigid image is extending in the anterior anatomy. You can also see a lateral extension there from the deformed image, so the model didn't quite predict those lateral extents, but overall quite good overlap seen. Similar for the bones, you can see the pelvis, a bit of misalignment occurring there, but most of the misalignment from the bones occurred in the rib regions. You can see where there's the overlap is missing there, and similar for the kidney and liver. When it comes back around, you can see that most of the misalignment was occurring in the extremities, but for the most part, the overlap was quite successful. So now moving on to the actual clinical plan evaluations. So this was on the first test case that you've just seen CTs of back there. And overall, the synthetic plan, so this was planning on a synthetic CT from scratch, done by Milad, which I'm very thankful for. Plan from scratch on that, and then apply it to the planning CT and the diagnostic CT, and use the different organs at risk contours, but not re-optimizing that or using any normalization. And yes, you can see the difference in the CTV between the synthetic CT and the planning of only 0.36%. And while there is a large difference in the dose to the kidneys, it's all well below the constraint that was set. And the spinal canal dose is very, very comparable between the synthetic and the planning, while it's quite significantly more different for the diagnostic plan. And this is all affirmed by the DVH here, where you can see quite close adherence of all the lines, except for just that the spinal canal, the distribution there for the planning CT. And for the same test case, looking at the isodose maps, you can see all cases had very high conformity to the PTV. They all pushed dose well away from the kidneys. The planning CT, you can see qualitatively is the hottest with the largest 100% isodose wash. And also you can't see it here, but there are occasional 103% hotspots in the spinal canal itself. Now, this is probably arising from incorrect HUs in the synthetic CT. So it's not quite predicting that anatomy as well as it should. So it would be slightly denser. So then when you put that onto the planning CT, it's pushing a bit more dose through there than it should be, which I believe would be the case because the actual overlap of the regions is quite good. And meanwhile, the dCT being colder is likely from having the patient experience profound weight loss. So it's likely from having more tissue there for attenuation. And while the diagnostic plan did see greater spinal canal sparing, it may have compromised its actual treatment goals if you were to treat this patient, given the reduced PTV coverage. Now, this is another test case on a thoracic patient. And here you can see a very significant difference in PTV coverage now between the synthetic and the planning CT, which is affirmed by looking at the DVH line for the synthetic CT, which is quite a ways off from the other two plans. All of the organ at risk goals were met, but this is obviously the PTV is the most salient thing to focus on. And so if we look at the isodose for this plan, so this was actually a soft tissue PTV, just a butting vertebrae there. And what's happened is that due to how the model hallucinated extra, denser tissue in the lung there, when you took the plan from the synthetic CT and put it onto the original diagnostic or the planning CT, it was pushing more monitor units through that area than it really needed to. Hence why over here you can see a higher 107% wash in the PTV there and a higher D max. And the diagnostic CT is in between the two, presumably again due to the more anatomy in the anterior there. So looking at a collation of across all the goals, even with that thoracic case included, the average difference in the PTV across the 5 of the 10 test cases that were planned on was minus 1.41%, which is actually a 0.59% improvement in PTV coverage compared to the CT to CT translation study I showed earlier by Rowshanfarzad. And comparing this with Brani's average difference, absolute difference in CTV coverage of 0.27 gray, if we say compare it with the PTV average difference, it is markedly higher in this case. The improvement is perhaps related to Brani's dataset using more standardized PCT and CBCT acquisitions, while the diagnostic data came from a variety of vendors under different acquisition parameters. So finding a way to account for this to get more accurate HU predictions is of utmost importance. And it's important to remember that even though the diagnostic CT has a better dose adherence overall compared to the synthetic one, likely due to more accurate HUs, you would need to consider the difficulty of how you would actually treat them in that position. So that's what I mentioned before with those studies which used vac bags to recreate diagnostic couch curvature. But again, that's introducing extra difficulties and perhaps front-loading more work for radiation therapists here at Charlie's. So in conclusion, in regards to the first aim, end-to-end model creation was performed and it was trained and tested, and the image-based results were comparable with relevant literature, what small amount of directly relevant literature there was. And overall, this was improved upon, but it was poorer, the results seemed poorer when comparing to CBCT to CT studies. which of course it's good to remember that this is quite a different application, but still helps in comparison. And regarding the second aim of dosimetric evaluation, that was performed, and the plans appeared clinically acceptable in lumbar regions. However, as you could see, the prediction of lung anatomy compromised those thoracic plans and led to far hotter PTVs. So this overall suggests that SFRT is feasible for PTVs below the 12th thoracic vertebrae. Yes. So some future work that could be considered, so a suggestion from Brani to address the HU problem from diagnostic CTs would be a sort of style transfer model, so just training a model to convert arbitrary CT numbers to those corresponding to the CT at Charlie's. Also the development of an image level uncertainty metric, so I can't go into too much detail, but essentially I did a cursory uncertainty analysis of looking at error versus uncertainty and finding a means of essentially defining a failure mode for patient eligibility based on the uncertainty of the model would be a very good way for screening patients. And then there is, of course, refining the architecture, either improving on the current approach or going to something more state-of-the-art like diffusion models, and expanding on the data set itself. So a broader patient scope or more patients of a reduced diversity to make a more targeted model, and perhaps even looking across multiple institutions to improve overall generalizability. So just would like to acknowledge my supervisors. Firstly, I'm very grateful for Jake for his support and keeping me on the straight and narrow, and Pejman, as always, for his teaching, advice, and encouragement. Brani, aka the grandfather, as I call him, for I feel bad always bursting into his office, and I know he's a busy man, but I appreciate that he's taken a lot of time to help me out with deep learning, sort of workshopping and things. Milad as well has been amazing with his planning and just overall encouragement. I really appreciate that. And Suki, of course, is where this project came from to begin with, and he's also helped me out with RANSCA registrations and the machine learning cluster, Commander Barry, who can't be here, unfortunately. And of course, my peers for just generating a generally supportive culture, and the Charlie's team, especially Martin Mashid and Braden Cheong, the RT, who helped me with my data acquisition. And lastly, of course, the Charlie's Foundation for supporting the presentation of this research at the upcoming EPSM. All right, thank you very much.
Great job, Joel. Thanks for that presentation. We'll open up for questions if anyone has any questions for Joel. Rashid.
Thanks, Joel. This was fantastic. Just one question about how do you see this coming to the clinic? How do you think, how long it takes and what needs to be done to make it clinically available?
Yeah, well, another benefit of the model architecture I went for is that the time to produce the synthetic outputs is on a matter of seconds. So that wouldn't be too much of a problem. I imagine it would be, there were some pre-processing stages. So I made my pipeline as flexible as possible, but I would make some refinements to that, and I suppose package it in a sort of API, which could, it would perhaps require to fully integrate it with the software actually used at Charlie's would perhaps require some talks with the vendors, the relevant vendors, to incorporate an API for diagnostic image conversion. Otherwise, I think you could go about it. Well, yeah, I don't quite know the sort of ethical considerations and what would have to happen there. But for my part, it would be relatively straightforward to implement, because you would get you give it a DICOM image, and I refine the process to output a DICOM image, which can be easily imported into Eclipse and used for planning. There are other considerations around what a simulation session entails. So things to iron out regarding how you define your ISO center and what you're going to use for alignment when they're on the couch to make sure you're treating where you want to be. Perhaps that would be the navel region. So yeah, there are other considerations like that, of course.
Great, thank you. I think it's worthwhile to give this talk to our physics team also in the next journal club or so that everyone understands.
Absolutely, yeah. You're happy to.
Thanks, Machine. Joel, I might just follow on from that question. I guess the way that I interpreted Machine's question was potentially what sort of next testing steps you would need to actually get the model implemented into clinical practice. So if you were to design a sort of trial of some sort that would run potentially at Charlie's, how would you go about doing that? As a sort of general thing to test the model and take it to just that next level.
Sure. I see what you're saying. Well, yeah, with the model as is, you would absolutely restrict it to lumbar-only patients. Would start with just a relatively simple PTV, which I guess would you'd confirm that, I guess, talking with the relevant referring clinician. And then I imagine you would still want to bring these trial patients in for simulation sessions so that you have a very clear comparison as part of this limited prospective study. Although that said, I have seen other works which have completely foregone any sort of planning comparison, have just focused on the outcomes of the treatment. But I think that would be worthwhile given the nature of this sort of project. But I think patient screening would be very important. Because of course you're dealing with quite, although there are broader dose constraints, you need to consider the situation of these patients and reducing the treatment burden upon them. So yeah, would be careful and have a limited selection just to serve as a proof of concept, perhaps, if that answers your question.
Yeah, no, thanks, Joel. Yeah, that's pretty much exactly how I would have envisioned it. So yeah, thanks, Joel.
No worries.
Good answer. Any other questions for Joel? Brani.
Yeah, I had one. Great stuff, Joel. I can really appreciate how much work you put into this, basically tackling an extremely novel project, and it's basically uncharted territory in terms of the literature. So great stuff on getting a decent result at the end of this. So I just wanted to ask, if you had more time and resources, I know you mentioned a few things earlier, but if you had more time and resources, what improvements would you make to all aspects of this project? For example, the model, the workflow, the data, the fundamental concept, because clearly, as you go along, you don't know what the end result will be like. And especially with deep learning, that's kind of, you throw yourself in and you don't know if something's going to work or not, but you do learn a lot of things along the way. So if you had any kind of insights from your experiences, what would they be?
Yeah. I think I would have started a bit more conservative in my patient selection, and perhaps it would have been better to say, no, just do lumbar patients. And if I can get a model working well in purely the abdominal region, then sort of slowly build from there and incorporate more patients or see how well it generalizes to other parts of the body. Because as it is, the diversity of the patient cohort does introduce a few more uncontrolled variables. So start with that. And yeah, if I were to go again, perhaps refining the subset would be good. And doing away with any sort of post-processing obviously would be very good, to just have a model which can produce those highly precise, finely detailed outputs. I have a feeling that's not a limitation in the architecture, because my models by the end were quite hefty. I think there's perhaps just some nuances in the interactions in my loss relationship. So I think going back to the drawing board a little bit in some of those aspects of the training would also be good. I think the model architecture itself, even though there are more state-of-the-art models, there's also the consideration for how long they can take to produce an output. And the fact that this is the fact that it can produce output so quickly, I think, is definitely something worth bearing in mind. Yeah, I think those are the main aspects. So yeah, refining the patient cohort and just refining the architecture itself. Of course, doing more actual treatment plans, as that's the greatest assessment, would be great. and yeah, playing around with different PTV locations to give a more well-rounded appraisal of the model's performance as well would be good.
Yeah, I definitely agree there. I think if you look at commercial models for auto segmentation, for example, what you mentioned with having like anatomically specific models, like in your case, like that thoracic region or the specific regions you want to target, having separate models for those regions trained specifically on those anatomical areas would be a benefit. And yeah, definitely, I think if your model can basically nail those HU values, like it's predicting the anatomy quite well, those deformations quite well. So yeah, definitely almost there. But anyway, good stuff, Joel. Fantastic outcome.
No worries. Thanks so much, Brian. Yeah, again, really appreciate your assistance with this one. I was happy to carry the torch.
Thanks, Brani. Milad.
Hi, everyone, and thanks, Joel. That was a wonderful presentation. And I just wanted to mention something. And yes, in the future, it would be good to consider everything also for patients that have metallic artwork, like, they have spine simulators, anything metallic around the spinal region or in their abdomen. Obviously, as Brani said, and yeah, making it specific for different patients and basically what they have in their abdominal region, whether it's a metallic artwork or anything really. So yeah, great work, mate, and well done.
Thank you, Milad. Yeah, no, absolutely.
And see you tomorrow in Lanska.
Oh, you'll be there? Yeah, fantastic.
Yeah, I've got to go back. Yeah, but yeah, wonderful presentation, and thanks everyone.
Thank you, Milad. Thanks again for all your help with the project as well. Really appreciate it. And yeah, that's definitely worth keeping in mind. You want to keep it in many ways as generalizable as possible.
Excellent. I think we'll finish there. Thanks very much for all the questions, and thanks, Joel. Great presentation.
No worries. Thanks a lot, everybody. Appreciate it.
All right, we'll move on to Xavier now. Xavier.